Hello, welcome. Thank you so much for joining us for today's CHD Wise episode, Back to School 2021. My name is Rebecca Acosta, and I'm the Director of Education at Conquering CHD. We are streaming this event live this evening on Facebook, and we will also have the recording stored on our website at conqueringchd.org. On today's episode, I'm going to welcome Ms. Kyle Landry. She is the Director of the Educational Achievement Partnership Program at Children's Wisconsin Herma Heart Center. In case you missed her feature on our social media earlier this month, Kyle is also a CHD sibling. And special news, I think she's going to have some of her amazing coworkers join us for the Q&A portion this evening. Welcome, Kyle, and thank you so much for joining us again this year.
Thank you, Rebecca. I'm super excited to be here as always.
Great. So before I turn things over to Kyle, just have a few housekeeping notes for everyone watching live and also in our Zoom audience. If you are wanting to follow along with Kyle's presentation, make sure you download the materials on our website. It's conqueringchd.org/backtoschool2021. And she will be taking questions after the presentation, so make sure to utilize that Q&A box at the bottom of your Zoom screen to send in questions. All right, I'm gonna disappear for a little bit and Kyle, take it away.
Awesome, thank you so much. Pulling up my screen. There we go. Rebecca, can you confirm you see this properly?
Yes, you are good.
Okay, awesome. So many times you're like, all right, awesome. Hi, everyone. I'm so excited to be here tonight to share all things Educational Achievement Partnership Program and describe some of the ways that CHD families in and outside of Wisconsin can efficiently and effectively advocate for their neurodiverse learners with chronic and complex health conditions. As Rebecca said, my journey to the Educational Achievement Partnership Program is a very personal one. In 1987, my sister Lee was born with a previously undiagnosed hypoplastic left heart syndrome, or HLHS. Although Lee's time with us was very short, her life had a profound impact on me. As I went through school, I remained very interested in hospital projects and events, from building and maintaining a children's library of books that patients could take home with them, to working the phone banks during our annual fundraising events. My personal passion always remained in education. After college, I taught in the Milwaukee Public School District, where I specialized in enhancing learning opportunities for youth placed at risk for failure. Although my job title has officially changed to EAPP manager in 2015, my daily roles, responsibilities, and mission are still very much aligned to enhance learning opportunities for youth placed at risk for failure. During tonight's discussion, we will cover an overview of the Educational Achievement Partnership Program services. We will take a deep dive into advocacy and what to do when you notice delays, deficits, and differences with your child's academic achievement, regardless of if they already have special education supports in place or not. Review recommendations for making informed decision about in-person, hybrid, or virtual learning environments, and how to make the most of a virtual learning setting if that's the environment your child is in. And finally, talk about my one last step, or the one last step you can take to really amplify your advocacy in a school setting. First is the EAPP overview. So first, let's take a look at how the Educational Achievement Partnership Program fits within the context of traditional healthcare. Many cardiac programs offer neurodevelopmental assessments and family resource support programs that assess a child's development in areas of cognition, executive functioning, attention, behavior, social emotional functioning, motor skills, language development, etc. While this type of testing and care coordination is absolutely essential, the burden is often left on families to translate those scores and follow-up recommendations to the schools in meaningful and actionable ways. To address this, the EAPP worked to coordinate care beyond the scope of traditional related programs with school touchpoints by serving as a comprehensive extension of existing services. The EAPP's niche is education. In the past, we've been asked, like, what's your secret sauce? My answer is both simple and complex. Our team is made up of experienced educators who are specially trained in complex medical conditions and the impacts of surgery, treatments, and complications on cognition, physical health, and neural development. Not only does the specific skill set allow us to make pinpointed recommendations that are actionable and applicable in both general and special educational environments, but it also establishes a level of confidence when partnering with school teams. Since we've spent years on the other side of the table, we can speak both medical and educational languages fluently. This is an example of our coordinated communication system, which places the EAPP at the center of a multidisciplinary care team. This positioning allows us to serve as an information hub, ensuring clear and consistent communication among all stakeholders: the hospital and medical team, the family and patient, the schools and school staff, and other community care partners such as private therapists, OT, PT, speech, etc. The EAPP translates technical, medical, and educational information into languages that schools can understand and immediately act upon. By taking these communication roles and burden off families, that allows parents to just be parents. Our assessment protocol uses both survey and interview formats to consider the perspectives of multiple important stakeholders involved in the child's school achievement, including the parent or guardian, the patient themselves, teacher or teachers, and school or district nursing staff. We define each developmental domain. We ask questions in standard language, and we collect scales responses with specific examples of school challenges, and then the parent or teacher or nurse's own suggestions for support. These responses are then evaluated alongside medical and school records, which may include clinic visit summaries, neuropsychological assessments and evaluations, and also attendance, report cards, and past educational plans. Collectively, these stakeholders and record assessments provide us with a comprehensive picture of the child's educational functioning in different environments, at home, in the classroom, and in the community. While I have big dreams to one day partner with institutions across the nation to provide this level of comprehensive school support as a standard part of cardiac follow-up care, tonight's focus is to bring you our tips and tricks for effective advocacy. All right, so here is where I provided Rebecca with some handouts. You may choose to follow along with me during this presentation and write your own notes as you go. Obviously, I'm going to be going a little quickly, so you can just dash bullet points if you're interested, or save it for later and work on when you have some time to really dig in. So creating medically informed educational letters has been key to the Educational Achievement Partnership Program's advocacy success. These letters can apply to anything: first-time special education referrals or a request for reevaluation, first-time 504 plan supports or a request for reevaluation, even things like school-based health plans. You name it, these letters are my recommended first step. To create an effective letter, regardless of what you are asking for, you need to create a clear heart, brain, body logic chain. First, describing the medical condition or conditions in layman's terms, then describing how the conditions affect physical health and well-being, then the impacts of cognition and development leading to neuropsychological delays, deficits, or differences, and then finally how all of these things relate to classroom performance and challenges observed. We're going to go through each of those steps independently, but that's kind of the overview. This is a sample, the image is a sample of our medically informed education plan that my team provides. We've designed our MedEd referral letters to follow the criteria of an OHI checklist, which describes an overview of the child's medical conditions, the impacts of the child's educational performance, disability limitations, special education services and accommodations, and then we wrap up the letter with guidelines for school-based healthcare. While the qualification criteria for a 504 plan is slightly different than an IEP, there are very similar ways, and we found this template works really well for either. So you just need to ensure you're crystal clear about which of these we're asking for, but we'll dig deeper to that further in the presentation. All right, first part. So the first section is the medical overview. This is where you'll describe the child's medical background in clear layman's terms. What we typically include is the child's primary medical condition, surgical and treatment history, related complications, and prognosis. We also describe secondary medical conditions and related surgical and treatment histories. Then we describe the child's neuropsychological deficits and associated treatment and therapies. I'm not going to leave you hanging though. I'm going to be sure to give you examples throughout. All right, So looking at this first page, here are some examples of clearly stated cardiac diagnoses and descriptions of what it means in brief layman's terms that school staff can understand. If the child has several different diagnoses, they should all be listed in order of severity if applicable. And I want to let you know it's okay and almost easier for the reader if you bullet point the list. So this slide shows you some specific examples. 1 or 2 sentences is plenty to describe how the child's cardiac anatomy is physically different and how that impacts changes in blood and oxygen circulation. Google is your friend here. That's what I try to tell everybody. I search diagnoses all the time to write my layman's terms definitions. Just beware, with lots of different cardiac diagnoses and lots of different combinations of defects, you need to be sure that what you are describing actually matches your child's unique anatomy. For the next section, the body and health impacts, we simply need to make a statement about how CHD or other heart diseases or irregularities, as well as any other relevant medical conditions, can impact the body from a physical perspective. I generally have one, what I call bread and butter sentence that I use and I customize as needed to make this point clear. Here it is, I'm going to give you my language. Congenital heart defects, or CHD, and other pediatric heart diseases may affect blood oxygen circulation in the body and may cause unique baseline symptoms that may require rest and recovery, such as irregular heart rate, breathing disturbances, cyanosis, which is blue and gray coloring of the mouth, lips, and nail beds, low energy, fatigue, and may cause strength, vitality, and alertness limitations. If your child experiences additional symptoms as a result of their diagnosis, so for example, headaches, dizziness, stomach ache, body temperature fluctuations, etc., I urge you to add those here as well. Now we're looking at describing the brain and developmental impacts. Once again, I will share the statement that works really well for the Educational Achievement Partnership Program. And once again, you can choose to take it or leave it and customize it in a way that makes most sense for your individual child. Here's our example. Pediatric heart diseases, their treatments and related complications are known to affect normal blood and oxygen flow, potentially delaying pre- and postnatal development. Now we're moving on to the second part, which is educational needs. The educational needs section should span all areas, including academic, executive functioning, and social emotional needs. Here you will be making connections to observable behaviors that you see and can connect them to school challenges in the classroom. Like the prior slides, I want to share with you some of the language that has been successful for my team when making these connections to neuropsychological deficits and differences. In fact, scientific research studies have suggested that children with heart disease often score lower in hand-eye coordination, fine and gross motor skills, social emotional functioning, and language development than their typically developing peers. Behavior, attention, immaturity, and learning challenges are also much more common in children with heart disease. It's really nice when you include that general statement that's very much science-driven and fact-based, and then having additional sentences where you can customize it to your child's specific needs. All right, I often follow up this general statement, like I just said, with some CHD specific key discussion points. Again, these are all right from medical research. Educational concerns can arise at different stages of development from preschool through adulthood. New concerns may emerge as age level expectations increase in areas of independence, organization, attention, and academic skills. Subtle neurodevelopmental deficits affecting multiple domains are extremely common and often result in more substantial academic concerns over time. And neuropsychological deficits do not self-correct, and children should simply not be expected that they will catch up on their own. During this part of the letter, I make my formal request for an IEP or 504 plan evaluation or reevaluation. It can definitely be tricky to determine which plan best fits your child's needs, so we'll dig into that a little bit deeper in the next few slides to help you determine what your ask is. All right, looking at this chart, we're going to look at some of the differences between an IEP and a Section 504 plan. To qualify for an individualized education plan or IEP, a team must deem the child has limitations that substantially limit them in their classroom performance in a way that demonstrates a need for specially designed instruction and other modifications. This could be services such as one-on-one education, school-based therapies, curriculum or grading modifications, etc. An IEP is a formal, legally protected special education document. A 504 plan is a little different in that it also requires team qualification consensus and looks for evidence of substantial limitations of one or more bodily functions. The difference here is that a 504 plan allows accommodations to be made that allow equitable access to education with same-age peers, but does not fully modify the materials or the learning environment. Here's an example of the 4 main areas that need to be considered for eligibility for a Section 504 plan. The following 2 slides are looking specifically at Wisconsin criteria, but I do want to let you know that federal criteria is very, very similar in most states. The first question is, does the child have a mental or physical health impairment? In the case of our children with congenital heart disease, the answer is pretty much always yes. Does the child's health condition limit a major life activity? Now you can see where it might limit several of these. The ones highlighted in red, like learning and concentration, executive functioning, are common ones. But I also want to point out the one that says operation of a major bodily function, i.e. cardiac or circulatory. That's a pretty clear marker that yes, it limits one function. The third question looks at to what degree is the health impairment limiting this major life activity? It needs to qualify, it needs to be either substantial or extreme, which is one of the reasons in red. But the other reason is many of our patients require surgeries for immediate repair, in which case, to sustain life, there is a substantial intervention, which would qualify in that area. And then the fourth question, does the student require accommodations and or related aids or services to provide the student access to educational programming? This is the trickiest of the areas because you really have to prove that it's a necessary support. This is where you'll really want to pull out that logic chain and explain that health brain body connection and why those early intervention and services are necessary. Next, we're going to look at the IEP eligibility criteria. So this slide shows an outline of the IEP eligibility checklist, and it's for other health impairment or OHI. Because all of our patients have underlying medical conditions, this is likely the case for all patients with CHD. If they need special education, this is one of the areas or the most likely area they will qualify under. To be eligible for an IEP under OHI, all 5 questions on this checklist must be marked yes. First, does the student have a health problem, which we have already determined is yes. Is the health problem chronic or acute? So is it long-standing and is it severe? Generally, in most of our patients and students' cases, the answer is yes to both, but it could be either or, it does not need to be both. The third question is, does the student's health problem result in limited strength, vitality, or alertness? For alertness, we can look at over alertness as in ADHD, or we can look at under alertness. Only one of these boxes needs to be checked to qualify, but we found that many of our patients do meet criteria in many, if not all of these areas. The fourth question is the student's educational performance in one or more of the following areas adversely affected as a result. Similar to the other one, that there's some specifics and you really have to provide detailed examples of why you feel that way, but there's many different areas that a child could qualify under. Academic achievement, communication, social emotional functioning, behavior, the list goes on, and often they qualify in many areas. And the final, often most tricky check is, does the student need special education? This next section looks at recommended specific accommodations for the child. These can cover academics, handwriting, attention and behavior, executive functioning, social emotional needs, or distance learning specifically during the COVID-19 pandemic, but then also other long periods of home learning due to hospitalization or other illness. Our last section in our letter includes specific school healthcare guidelines with specific symptoms associated response steps, accommodations for health and safety at school, and those COVID precautions we really want the school to know about. All right, this is looking at a kind of assortment chart of accommodations that could be offered. On these charts, you'll find these sample accommodations that are often recommended for both IEP and 504s. I caution you when using them to be very selective and request only what you think the child absolutely needs. In this case, the kitchen sink method of kind of throwing out all possible options, or this sounds good, that's never an effective method. So being very, very choosy about where the child's largest areas of deficit are And also kind of selecting out which one of these are just general good teaching practice that doesn't need to be specifically addressed in a plan. This may also include some trial and error. Accommodations, once put in place, may need some time to yield results, and that's totally okay. Stay patient with the process and keep detailed records of what you're seeing as successful and what's not working. And as a parent, you have a right to call a revision meeting at any time to review the child's progress and revise the plan and accommodations as needed. All right, now let's talk about sending your completed letter. I highly recommend sending 2 copies. One, I always attach via email to all known team members. The second, I deliver by hand to the most appropriate contact. Sometimes that's a special education teacher that you already have a working relationship with, and sometimes that's just the classroom teacher if this is the first time you're really advocating or asking for additional support. At that resulting IEP or 504 planning meeting, as it gets closer, we always ask the schools to reserve 10 or 15 minutes at the very, very beginning of the meeting for my team to provide an update, but also in your case, for you as the parent or family member to provide an update that sets the meeting off on the foundational heart-brain-body connection. So I strongly encourage you ask for that 10 to 15 minutes of protected time at the start of the meeting as well. All right, so for this part of my talk, I want to really load you up on how to be proactive and advocate for your child during that first 10 or 15 minutes at the beginning of the meeting. These are like items we've used that have had really proven results that I am happy and excited to share. The first is getting an understanding of the school staff knowledge gaps. So in 2019, my team really dug into what do schools actually know about our patients. So in reaching out to schools, we set the stage up like, we're not quizzing you. We're not trying to catch you off guard. We really need to know what you know, so our program fills in those gaps. What we found out is 86% of school nurses and 76% of our patients' teachers knew the child had a cardiac condition. Well, 86% and 76% are like pretty high percentages. That's still 20-ish percentage of people that weren't even informed of the medical condition at all. Then you can see those numbers get kind of scary. Only 34% of school nurses and 22% of teachers knew that that cardiac condition could increase the susceptibility to illness. Only 32% of school nurses and 27% of teachers knew that that cardiac condition could impact learning. And only 25% of nurses and 19% of teachers knew that that cardiac condition could increase the risk for developmental delays, meaning how many missed opportunities could there have been for early intervention? All right, so this is prepping for that school meeting and what you can do to be a really strong advocate. Again, remember to send off your letter with that request for 10 or 15 minutes at the very, very beginning. I can't even stress that enough, at the beginning of the meeting, to really share this information verbally with the team. Review your key talking points ahead of time and practice delivering clear and concise messages. These are my child's medical conditions. This is how their brain and body is impacted or at least at risk. And here are my concerns that I would like to discuss with this team today. Then you supplement your talking points with pictorial representations of the child's condition to help explain and visually show why the medical condition is impacting the school experience. As always, I'm not leaving you alone. I'll give you some examples. So here's an example of an image that we would use for a hypoplastic left heart syndrome patient. Again, you don't have to have all of our fancy children's materials. If you have a picture or a diagram that your cardiac center has provided you, that's a great starting point. But remember, Google, you can also search all of these different cardiac defects and combinations of defects. Again, please make sure it's actually correct. And represents your child. But this is a really good visual way to show a school team how your child is very, very different in terms of cardiac anatomy. Yes. What we do following that is we often show this graph as well. And what it shows is the impact on brain connectivity for pediatric heart disease. And what we see is children born with CHD are often have similar brain connectivity hubs to children who are born prematurely. So what you see is fewer hubs in the CHD brain and fewer connections between those hubs. And I'm going to give you my key talking point right now in a meeting is what I often say is Let's compare this to telephone lines, right? Everybody understands cell phone towers. If you have fewer connectivity hubs and fewer connections between those hubs, calls are going to get fuzzy. Sometimes they're going to drop. And I promise you, just giving that analogy, you will be able to look around the room and see heads nodding, because often that's the first time people get that connection of cardiac disease or defects to brain functioning development. I also often share this neuropsychological deficits graph with schools. Purely what it shows is the higher the severity of the congenital heart defect, the higher the risk for developmental differences. Then I make sure that I discuss and state the different neuropsychological risk domains. We talk about physical development, language, social emotional functioning, attention behavior, executive functioning, and cognition. What I want to point out here is your child does not have to have delays, deficits, and differences in all of these areas to bring it up. Just having the conversation that these are potential areas of risk really heightens school staff awareness of what to watch for and what to monitor for. And when they start seeing slight differences, have that perception that maybe this is an area where early intervention needs to begin. Another area I really discuss with schools is how neuropsychological deficits can onset at different stages of development from birth through adulthood, again, as independence, organization, and academic skill levels demand. Opportunities to improve these school performances obviously are greater with early intervention. The younger a child is, the more opportunity we have to really support them and give them those tools in their toolbox. Just because a child is older, that doesn't mean we can't support them, but this is often where the appearance of academic concerns come out and the opportunity to improve really declines pretty rapidly. All right. Again, this is looking at the education plan eligibility. It's discussing the chronic and acute nature of the child's illness, where just like we did with the letter, we're giving specific examples of strength, vitality, and alertness limitations. We're explaining how those limitations affect educational performance and providing those examples to the school team. And then we're recommending specific services or accommodations. You can even refer the team right to that med-ed referral letter and say, because of these are the accommodations that I'd like to discuss today. So you do not have to specifically ask for anything. You do not need to demand anything. You need to just bring the attention to, these are the areas of concerns, and this is where I'd like to focus team energy on today. Then looking at that school health plan section, that's always the very last plan of our letter, very last section of our letter, I'm sorry. But also something that needs to be a verbal conversation in that 10-15 minutes with the school. So this is really an area where you want to describe symptoms on a continuum spanning from mild, moderate, elevated, and emergency symptoms, along with the associated response steps. So it's our goal to ensure that all school staff who work with the child know when it's safe to keep them in the classroom and really, staying where they belong. When it's necessary to impose a recovery break, whether the child's asking for one and the school really needs to grant that, or the child is not asking for one and they're going about their day and they're, turning red and sweating, and where you really need to stop the child and say, hey, maybe it's time for a break. When to send the child to the nurse, when to call home, and then of course, when to call 911. Also in that school healthcare accommodation section, or a talking point for this meeting, is discussing basic health and safety, expectations for hand washing, sanitizing objects, the sharing of food or drinks, etc. Talking about self-limiting activities. So really giving that child permission to stop an activity or slow down an activity without grade penalty, without restriction, and taking those breaks as needed. A conversation about water intake and bathroom use. Often our kids require access to fluids at all times, encouragement to drink, and then with that, access to use a bathroom as needed. Talk about a plan for school absences. So how we will have absences excused with medical provider documentation, and then a plan for how to handle missed schoolwork. And then finally, the new one that we've all kind of had to add is COVID-19 precautions. So a discussion of either what the school is doing on their own or how you'd like your child to be handled differently or independently, whether it's face masking, social distancing, etc. And then kind of a last last key talking point is making sure the school has a school-wide cardiac safety plan. So that's really having an AED that's accessible, having a cardiac response team. So there's a designated staff members who have coordinated what to do in the event of an emergency, having that emergency response plan that's reviewed and practiced, knowing CPR and AED use. These, like 99.9% of the time, will never impact your specific child. But because you have a child with congenital heart concerns, you have a platform to speak upon that may likely impact another student, or more likely teacher, parent, grandparent, referee in the future. So really utilizing that platform to be an advocate for heart safety school-wide. All right, now let's talk a little bit about virtual learning and access, because this has kind of thrown a wrench in everything these past year. So we know guidelines are changing and school districts are working very hard to develop plans, or develop and finalize plans. I urge everyone to check with their specific school district to really understand what the guidance is, what the recommendation is, what protocols will be used for staff, students, and visitors in the fall. And I want to let you know that there's no right answer, and somebody is going to be upset no matter what they do. And we need to be flexible and adaptable while keeping our children safe at all times. So knowing that there's little we can change, but there's ways we can advocate and work proactively to keep our child as safe as possible within whatever protocols a school decides. The first thing I just want to touch on is the Center for Disease Control, kind of their newest recommendations. So given the new evidence about the Delta variant, the CDC has updated their guidance for fully vaccinated people and recommends universal indoor masking for all teachers, staff, students, and visitors to K-12 schools, regardless of vaccination status. The key point here is that children should return to full-time in-person learning in the fall with these layered prevention strategies in place. What this says to me is, obviously, COVID-19 is still a concern, but having children in school is a priority. This is just a review of risk of exposure to COVID-19 at school. Obviously, lowest risk is students and teachers engaged in virtual only activities and classes. There's a larger risk with small in-person classes, activities, and events. Different ways to group students together to maintain as safe an environment as possible within an in-person setting. And obviously, highest risk is full-size in-person classes, activities, and events. But both the CDC, like we talked about, the American Academy of Pediatrics, and me personally, in many ways, feels very, very strongly about the importance of in-person learning. So I just want to touch on those key points. The AEP strongly advocates that all policy considerations for school COVID-19 plans start with the goal of keeping the child safe and physically present at school. We do know from the past school year that opening schools generally does not significantly increase community transmission, although we cannot say it doesn't, and obviously we wouldn't. But the AEP believes that at this point in the pandemic, given what we know about the low transmission rates in schools, when proper prevention measures are used, together with the availability of effective vaccines for those who can have them, the benefits of in-person schooling outweigh the risks in all circumstances, almost all circumstances. So returning to school, obviously this is a case-by-case basis, and I'm never advocating for a family to do something that they are not comfortable with. But as a general population with the goal of returning to school safely amid the pandemic, there are a number of factors, including the severity and complexity of your child's medical condition, that need to be considered. It's essential to review your school's guidelines to help determine whether or not you feel comfortable returning to school. And obviously the frequency of COVID-19 cases varies significantly between counties and school districts. So just things to consider when making that decision. Also a list of some important school choice factors. So important factors involved in deciding whether or not to send your child to in-person school for this upcoming year include their overall health and safety at the moment, their ability to learn and progress successfully in a virtual learning environment, their access to special education services and accommodations, the potential loss of instructional time and access to those important school-based therapy services, mental health in general, and coping with that isolation from peers, the missed social opportunities, and the potential development of anxiety, access to internet and technology in the home setting, parents' ability to monitor, assist, and or provide teaching instruction within the home, and of course, the financial implications of missing work or having to hire another caregiver to supervise the child in the home setting. And what I always recommend is 2 sets of questions. And if you were with me last year, you know my recommendation was the same. The first is to have a set of questions to ask your child's medical team to help make these decisions. The first important question is my child at greater risk for contracting COVID-19 because of his or her underlying health condition? Is my child at greater risk for a severe related complication because of his or her underlying health condition? How can I keep my child safe during COVID-19? Can my child safely return to school in the fall? Does my child need to wear a mask at school? Does sending my other children to school or daycare put my child with the underlying health condition at risk for contracting COVID-19? And will the medical team write a letter stating that I need to stay home from work to care for my child? From my experiences, all of these answers have pretty consistent. All of the providers I've experienced have given pretty consistent responses across the board, but I really advise you reach out to your providers, even if you think you might know their answers, just to kind of get that piece that what you're doing is right for your child. Just like asking medical providers, I urge parents to question their child's school team as well. The 5 top questions I would recommend is asking, can accommodations be added to my child's IEP, 504, or health plan to ensure that my child receives teacher staff support following safety protocols at school? What virtual instruction changes have been made to improve remote learning? This says for the 2020-2021 school year, but it should be the 21-22 school year. Or will that virtual instruction be similar to last year? If my child begins the school year with virtual instruction, but still struggles significantly, what resources will the school offer to improve my child's ability to learn and participate? How will my child receive their special education services and or therapies? And what should I do if I am concerned that my child is falling behind or regressing in specific academic or developmental skills? All right, and then the third slide I just included is there's some similar yet different questions for a college age student to be asking as well. Responses will greatly vary by university, but my top 3 recommendations are asking, what is the process for applying and qualifying for accessibility resource services to secure accommodations related to my cardiac condition or disability related learning needs in COVID-19? Will all classes have sections offered online? And if not, can virtual learning options be offered as a medical accommodation? And what is the process to apply for private rooming and or bathroom access as medically related accommodations while living on campus? All right, that one last step I had mentioned earlier. My one last step and piece of advice for you is that I urge you to talk about the importance of school support as a natural extended component of cardiac follow-up care and advocate for school liaison support within your own hospitals, health centers, and cardiac centers. The work we do is very important because it's definitely a gap and an unmet need, translating that medical information and educational information in a coordinated way. So I definitely invite you to call on me. I'll provide my information as well, to call on me if you have questions or concerns or want language to talk to your care providers. Or to give them examples of other hospital systems such as Children's Wisconsin that are doing this type of work, how it's funded, how it's supported, and how it's working. I'd be happy to share that with anyone at any time because I'm really proud of the work we've done and the outcomes we've had. All right, again, those hospital school partnerships, it works both ways. When both teams work together, we get the best outcomes for children. The hospital teams and the school teams have different areas of expertise. Let's build that partnership and collaborate to promote health and school-related quality of life in all environments. And here you go with my contact information. Again, I definitely invite you to reach out with questions and ways you can advocate for your child in the school environment, but also ways you can advocate within the hospital setting. And Rebecca, I will turn it back over for you to have some questions to see what I can discuss and get into.
Great. I think we're going to have some good ones. First, I just want to thank you, Kyle, for always being so passionate and eager to jump in and help whenever I call. I just adore you to pieces. And this information has helped me and my family and many other families. So we really, really appreciate your work. I do have a couple questions. Let's see, Carissa in the chat asked if a school doesn't have a Project Adam type plan, how can we help them get started? And can you give us some more information about Project Adam?
Yeah, sure. So Project Adam began at Children's Wisconsin, actually after a very unfortunate event where a child's school did not have access to an AED. But the parent really started a very, very strong advocacy program, and it has now spread nationwide. I think it's like 13 to 15 different states throughout the nation. That said, you don't need Project Adam to advocate for school-based cardiac emergency response. AEDs obviously are available all over, and just speaking to a school about the importance of having an AED available, having a team that can respond to an emergency in a way that's planned and practiced and coordinated is going to be beneficial for everybody without needing a program attached to it.
Absolutely agree. The next question, also from Carissa, she's got some good ones tonight. She asked, how do we bring up these heart facts if we already have a 504 plan in place for our child?
Yeah, that's a great question. Really easily. One of the things I had talked about is these letters and asking for that time in the beginning of a meeting does not need to be tied to any particular request. If you have a 504 plan and it's working, that is great. If there's things you want to add, but they're like maybe not necessary, it's a really good time to just wait for the annual review. But if you're looking at it and thinking, well, this is working, but this isn't, or these revisions sound good and could benefit my child, a parent can ask at any time to review review the plan and make revisions as necessary. It's a super collaborative process. And at that point, you can really bring up every single thing we listed. These are known facts for congenital heart children. This is medical research that you could look up. I mean, you could look up and provide tons of different research articles, but just sharing that this is a common known trend, and this is how I see it in my child. And these are areas I'd like to discuss today. Totally applicable if you already have an IEP, if you already have a 504, if you think maybe there's just a few more things, or maybe there's a whole lot that could be done to really beef this plan up and make sure my child is supported comprehensively.
Great. Catherine asks, her son's school has made masks optional for next year and removed social distancing measures, including the virtual education option. So her child has already been recommended for behavioral therapy without a 504 plan, but would you recommend putting one in place due to COVID concerns?
So COVID specifically, I would recommend a health plan. Because that's like just the obvious direct link. Because my child has these medical concerns, I recommend, you would have to recommend that they stay masked. You can't recommend other children staying masked or distanced, which schools can absolutely do. For the behavioral part separately, yeah, I think that would be a really super applicable 504 plan. I know there's tons of connections between congenital heart defects and congenital heart disease and behavior issues. So that's a really clear, easy link. So if that's what the main goal is, I think a 504 plan is totally applicable. And then at that point, you could tack on some COVID precautions. But if your real goal is COVID safety, aside from the behavior, I think a health plan meeting would be the way to go.
Great. And Ashley just submitted a similar question.
Yep.
What options or recommendations would you make for a school district not offering virtual learning and also stating that mask wearing is voluntary for students and teachers? So I think a lot of people are going to come into that.
Yep. I think that's going to happen a ton. And I think you can recommend that your child remains masked and your child remains distanced. That's not ideal for anyone. But that's something you do have control over, where you don't have control of what the other families are choosing to do. Without the virtual learning option, it's going to be challenging, because then you have either your school remaining in your school in person, or you can look at virtual options and virtual schooling aside from your school district as a entirely new school path. But I think if you're liking school and it's meeting your child's needs and it's just the COVID specific, I would look at options to protect your child proactively.
Great. I think so many families are going to
Yeah.
find that advice useful.
Yep.
Our next question is from Christina, and she asks, would homebound services be able to be provided for siblings if their sibling needs to be illness-free for the first month of school? For example, they have an upcoming procedure, or is homeschool the only option for siblings?
Yeah. Sorry.
I'm sorry. And then does home or hospital bound services mean that our children will only have a couple of hours of tutoring a week or day and the parent assumes the responsibility, or is it more collaborative?
Yeah, really good questions. I want to make sure I get to all of the parts. I do not believe there's probably any situation in any state where homebound services would be offered to a sibling. I think that's probably across the board, not applicable. They would be pending a medical provider referral, that the medical provider really believes that child cannot be in any exposure environment. Homebound is totally appropriate for that child. It's the school that decides how many hours and days per week that those services are provided. I want to be very clear that it's very minimal. Generally, I guess that's a generalized statement. It's often very, very minimal, 1 or 2 hours, a couple days per week. And to do more than that, yes, it would be on the parent to provide.
Great. So I don't have the question here, but I'd received an email earlier this week from a family that has a child that went through transplant process, very successful, and they're doing well now.
Awesome.
Would homebound services be something that would be a good choice for them if they are not able to go to in-person school?
Yeah. So from my perceptions within Children's Wisconsin, our transplant kids generally, maybe always, without saying generally, but I'm just going to go with generally, always qualify for homebound services for the first 3 months. So that's really that recovery period where we're keeping out any germs whatsoever. Because of COVID, I believe medical providers may consider extending the recommendation for homebound services for a longer period, although that's going to be case by case by center. But definitely something to look into during that quarantine period when a child is really first recovering from transplant.
Great, thank you. And this is just a question for me from my advocacy background. A lot of times families are receiving information and their child might be in the 5th grade or 7th grade, a little bit further down the path, and they had no idea that there was a connection between CHD, the cardiac stuff, and the neurodevelopmental issues. So what would be your top couple of bullet points of advice? Where do they start? How do they even process all of this in order to advocate for their child?
Yeah, we get that all of the time. We have our littles, which I love when we get the littles, because we're able to intervene at a time before they have school avoidance, before they hate school, like when they still genuinely love to learn. If you are seeing these differences later on, that 5th grade, that 10th grade, we'll go all the way up to the college point. That's generally the areas, as I had mentioned in the presentation, when independence and skill level demands really increase. And now we don't have that hand over hand support that we had by teachers previously. And all of a sudden, maybe I can't do this the same as my, same age peers. Totally, it's totally normal to see it and identify it more as the child grows. And that first step is really speaking with the child's teacher, seeing if they're seeing the same things in the classroom that you're seeing at home, assuming that's where you're observing it. And honestly, as soon as possible, get these conversations started of, I would say very rarely the first time you're noticing anything would go to an IEP. Maybe it's just a general education conversation about good practices in the classroom. Maybe it's a little beyond that, and we're looking at 504 plans and ways to modify small things just to make sure that child is getting equal access. But the sooner we see it and can have that conversation with the school team and then request an evaluation for the different plans, if that's applicable for this child, the sooner we can do it, the better off they are getting the supports they need to move forward in a productive, happy way.
I like that you say productive and happy.
Yeah, happy is the key here.
Right. Another question we get a lot are what is some of the lingo that parents should be familiar with? We know that there's so many different languages between the medical jargon and the education jargon, and we can't be experts in all of those. But for families just starting out with no knowledge, what are some of the things that they might IEP 504 and those type acronyms and jargon? What can they expect, and what should they really know?
Yeah. So IEP and 504 in terms of and like health plan in terms of what you're asking for or what you're considering for your child. But honestly, the first thing I would say is like, forget the jargon. Get a layman's term understanding of what's going on with your child. And this can start like at the very medical level, like in clinic visits. Get that clear understanding in ways you can easily comprehend and then easily can spit back to whoever your audience is of what's going on, what's the anatomy look like, and what's that difference, and how does it impact, how might it impact my child in health and safety, in terms of health and safety, and in terms of developmental progress. So you really have that clear understanding without the medical jargon. That'll really help you set up to speak to anyone you need to in a way that they can understand what's going on as well. Mm-hmm. And then obviously when we're getting into like the educational achievement section, the special education services like the IEP and 504, and just knowing the difference. I know my slide talked about it, but doing some research on your own, knowing the difference. So when you go to a school and ask for an evaluation, what you're asking for is something that the school can obviously see, like, I understand why the family is asking for this. So really getting the understanding. And my other piece of advice, which has nothing to do with jargon, but I'm thinking of it while we're speaking, is knowing your parental rights. You often hear schools say things like, it's too late in the year to evaluate, or I don't think we should do this evaluation because they're not going to qualify. Like, you hear all of these things that I think are well-intended messages from school staff. But well, first of all, they're illegal. But second of all, know what you can ask for and when you can ask for it, and know when you can push back. If they, it's too late in the year, it's, I don't know, May 13th, and the school says, I'm sorry, April 1st was the last evaluate. No, like, I'd like my child to be evaluated now. Knowing when it's appropriate to push back, and you're not like the squeaky wheel, you're just clearly advocating that you know your rights. That'll make a huge difference.
Do you have any tips for resources where parents can learn about the rights? I know rights, special education laws, and is there any other thing that you suggest? Because I can link that into our website. Well,
so here's the hard part, right? It's by state. So I suggest going to your state's Department of Education and kind of poking around there. Because I could give you recommendations for Wisconsin, but I know that's probably not helpful to everybody.
Great, I can put that note in there. And then one last question that I get a lot, and I used to have as a parent with younger kiddos. If my center is not a large cardiac center with comprehensive services, and my cardiologist or my child's cardiologist doesn't necessarily stay up on the latest neurodevelopmental research, how can I advocate for my child to have evaluations when my cardiologist doesn't necessarily understand?
Yeah, that's a really good question.
Yeah, we get that a lot.
Yeah. And so Children's Wisconsin is very rich in psychosocial resources. So I have to like put myself in that frame of not having the next place to go. I would think first of all that there's just, like I said, tons of medical research out there where you can look up and inform yourself. But if you really need that evaluation, I think looking at outside providers, I think every state has them. They might not be like extremely local, but finding where you can get neurocognitive assessments privately would probably be your next best bet. But also like not ending that conversation with your cardiologist, right? Like, okay, maybe this time they didn't have the resources or have the knowledge of where to direct you to, but making sure you bring it up. So this stays at the forefront of their minds, and whether they know it or not, they're in the future looking for different resources to connect families with.
That's great advice. Thank you. For everyone watching, I will put all of these references and resources on our website at conqueringchd.org/back-to-school-2021. I tried to make it shorter, you guys, I promise. So, but again, thank you, Kyle, so much. We adore you. The work that you're doing at Children's Wisconsin is just amazing. And I cross my fingers every day we can copy paste you into other centers. So
thank you. I say it all the time, but I genuinely mean, if there are questions or thoughts or things any family wants to bounce back and forth, I can't come out to your school and give the presentation for you, but I will never say no to helping you find the language to advocate for your child's unique needs.
And this is why we love you. Thank you so much again.
Thank you.
Yep. Have a great night, everybody. Thank you. Until next time.